Welcome everyone. So my name's Haidee Eves. I'm work at University Hospital Southampton in England, and I'm the senior specialist pharmacist in the nutrition support and intestinal failure team. Just to confirm, I've got no conflicts of interest to declare in producing this presentation. So just a bit about me. I graduated at the University of Nottingham in 2017. I then went on to do my pre-registration year at a local hospital, Hampshire Hospitals, in 2018. I then went on to do my postgraduate diploma in pharmacy practice at the University of Reading in 2022, and then completed my non-medical prescribing, also at the University of Reading, postgraduate certificate of this year in 2024. I've been a nutrition support intestinal failure pharmacist for going on 6 years, and what I really enjoy about this role is I feel like it's quite an under-researched area of practice, and therefore feel there's lots of opportunities, for example, coming to speak to you guys today. But also the patient cohort that you work with, the difference that you can make in their lives for the fact that they can actually go home and live their life rather than either be in hospital for a prolonged period of time, if not forever, if this opportunity wasn't available, or the fact that they could potentially die. So the fact that you can make such a difference to their life, and you see it on their faces as well when they can leave hospital, is so rewarding in this role. I also have key interests in medication management in intestinal failure patients, and also creating contingency off-the-shelf prescriptions for patients, which unfortunately happened due to COVID. But that is an interesting part of the role. So first and foremost, one of the main objectives today is to understand the role of a nutrition support intestinal failure pharmacist. And to do that, I'm kind of going to go back to the beginning and first of all discuss how we become nutrition support intestinal failure pharmacists, a bit about non-medical prescribing, and then the roles of a general clinical pharmacist, and then also specific to the nutrition support team. I'm going to discuss the HPN setup at UHS and just discuss a few case studies as well. So I've got a little poll. I'm hoping it's going to work. So it's just to essentially work out who I'm kind of presenting to today. Right, so there's a little QR code. As I said, I'm hoping this will work. If you can reach it with your phone, it's great. If not, there is a little website. And apologies for all the E's in my name, but there are 3 E's in there. So lots of dietitians, which is great to see. There are a few others. I don't know if it's just because they're not working in the hospitals. Is anybody willing to volunteer their other role? I wonder if it might be. Oh yeah, go for it. You're a nurse? Not a specialist nurse, just a... Got you. Where area of practice do you work in?
Never just a nurse. Actually, I work for TCP Homecare.
Got you. Thank you very much. Okay, so thank you for that, by the way, and taking part. So first of all, I'm going to start from the beginning in terms of our kind of where we go in our careers from when we qualify and on the register to how we kind of progress in our careers. So the clinical pharmacist career progression. Apologies, this is obviously based on the UK system. I haven't worked or grown up in Ireland, so this is based on the UK system. Okay, so first I'll start off with the post-registration foundation pharmacist curriculum, and this is based on the Foundation Pharmacist Framework, which is developed by the Royal Pharmaceutical Society, or RPS as we call them, and this is the professional leadership body for pharmacists in England, Scotland and Wales. And actually from 2026, all newly qualified pharmacists will be coming out as prescribers, so they won't need to undertake the non-medical prescribing degree anymore. But this framework provides a structured pathway for them in their early post-registration process. And the postgraduate diploma, which I conducted and completed in 2022, is aligned with this RPS framework. So then after a few years, you then move on to the core advanced pharmacist curriculum, and this outlines the entry-level standard for advanced pharmacists in patient-facing roles. It includes a credentialing assessment to ensure pharmacists have the necessary capabilities to practice at that advanced level. And the postgraduate certificate in non-medical prescribing is aligned with specific parts of this curriculum. And obviously the newer qualified pharmacists won't need to undertake that. So both curricula consist of 5 broad domains, which are closely aligned with the 4 pillars of practice. So you've got pillar 1 being person-centred care and collaboration, and also professional practice. Pillar 2, leadership and management. 3, education, and 4, research. Then you've also got the consultant pharmacist credentialing process, which defines the entry-level requirements needed to qualify for approved consultant pharmacist positions. And my manager at work has recently, in the last, I think it's the last year, has just become a consultant pharmacist herself, which is very exciting for our team. We have the General Pharmaceutical Society, which serves as our regulatory body in England, Scotland, and Wales. So to become a nutrition specialist nutrition pharmacist in intestinal failure, we would need to be at a level of at least an advanced pharmacist practice. And actually, advanced pharmacists do demonstrate advanced pharmacy level in practice on a similar level to an advanced clinical practitioner. So we are working at a fairly high level and fairly kind of complex situations that we are working in. And as I said, this can be achieved through the completion of the RPS Core Advanced Programme of Assessment. So now I'm just going to touch on a little bit about non-medical prescribing. So this term encompasses healthcare professionals, excluding doctors and dentists, working within their clinical competence or scope of practice as an independent or supplementary prescriber or community nurse practitioner prescriber. And to become that non-medical prescriber, you would need to undertake as an individual an accredited programme which is delivered by a higher education institute. So as I mentioned, there's 2 types of non-medical prescribers, supplementary and independent. The supplementary prescribers are required to have a partnership with an independent prescriber, either a doctor or a dentist, and they create a clinical management plan. And that clinical management plan is for specific patients, which is then signed by that independent prescriber. And within that clinical management plan, there are certain medicines that they can prescribe. However, an independent prescriber, there's no clinical management plan. They are wholly responsible and accountable for themselves in the work that they do. They assess the patient, they can diagnose, confirm diagnoses, and then they can prescribe essentially anything, apart from certain drugs for apart from certain controlled drugs for addiction. But obviously it is advised and preferable that they do prescribe within their scope of practice. So as a nutrition support and intestinal... Sorry, I'm coming back to that slide, but this is a rough kind of timeline of when we became independent prescribers and supplementary prescribers in the UK. So 2003 we became supplementary, and then 2006 we became independent prescribers. And actually in 2016 our dietitians became supplementary prescribers. So what is the role of a general clinical pharmacist? So you may already know this if you've got pharmacists kind of on the wards yourself. But a specialist pharmacist, also known as an advanced practice pharmacist, is a highly qualified autonomous clinician with expertise in a specific area. We possess an in-depth understanding of pharmacotherapy pharmacology, including the pharmacokinetics and pharmacodynamics of medications. We play a vital role in delivering high-quality patient care whilst helping to prevent unnecessary complications, medication misuse and adverse reactions. A key aspect of a clinical pharmacist's role is determining the most suitable medication for each patient. And these decisions obviously must be made efficiently and promptly. In addition to prescribing, we're able to counsel patients and monitor the effects of prescribed medications. Another responsibility is recommending appropriate administration routes and dosages for specific patient needs. Clinical pharmacists also serve as an invaluable resource for patients and healthcare professionals, so you guys. We can advise on safe medication combinations, provide solutions for specific patient concerns, and also offer information on potential side effects and check interactions with existing treatments. Our responsibilities extend to overseeing the supply of medicines used in the hospital. We manage the purchasing, manufacturing, dispensing, quality testing of medication stock with assistance from pharmacy assistants and pharmacy technicians. And this role can also involve generating cost savings. So, for example, I'm hoping to, in the next few months, depending on time available, but I'm hoping to conduct a quality improvement project whereby we're replacing iron vitamin D with potential an oral mucosal vitamin D, which is a lot less in terms of the cost, obviously depending on the outcomes. Hopefully they're favourable. But as Karen mentioned, a lot of our patients can't absorb their medicine, so having that oral mucosal vitamin D could be a lot better for the patient, not only for pain, but also potential for absorption. So moreover, we share expertise to support other healthcare staff and improve service delivery through those QI initiatives and research. And these roles that we undertake all align with that RPS framework that I previously mentioned and those 4 pillars of practice. So the bit that you've obviously, I say, all been waiting for, but the role of the nutrition support intestinal failure pharmacist. So as specialist NSIF pharmacists, we assess patients receiving intravenous supplementation. We can evaluate line sites, ensuring they're safe to use, and monitor for things like edema. We can also perform physical assessments, such as abdominal examinations when necessary. We're responsible for evaluating patients' nutritional needs and providing guidance with oral nutritional supplements, enteral feeding regimens, and also parenteral nutrition. Our expertise extends to optimizing PN formulations by offering advice on compatibility, stability, and also drug-nutrient interactions. We also assist in managing supply issues when necessary. We oversee PM prescriptions for both inpatients and outpatients, and therefore we in our trust and many of the units in the UK, we're the ones who manage the home care side of things and the HPM prescriptions and deliveries and all sorts of other queries that come about. And actually in the UK, NHS England actually mandates that all home PM prescriptions are screened by a pharmacist. We also play a key role in advising on management plans for patients requiring intravenous fluids and also electrolyte replacements. Another principal responsibility for NSIF pharmacists is reviewing medications, obviously, including administration routes and ensuring compliance with legal requirements, for example, administering medicines down NG tubes. We also maintain strong links with primary care by facilitating coordinating patient discharges, facilitating a smoother transition for those returning home on home intravenous support. Additionally, we can provide guidance on antibiotic use in catheter-related sepsis and micronutrient replacement. We maintain close communication with the technical services unit within the hospital and collaborate with them to support their delivery of services. And also, as independent prescribers within that multidisciplinary team, we contribute to improving service provision and efficiency by, for you doctors, alleviating some of those prescribing pressures. So, as I mentioned previously, we as independent prescribers work within a scope of practice, and this is a kind of not necessarily exhaustive list, but a rough scope of practice that we work within to support the team. So we have the artificial feed section, so we can prescribe oral nutrition supplements, enteral feeding tubes, and as Karen mentioned, we support distal feeding, including salt supplementation, and obviously parenteral nutrition. You've got the medicines which affect the GI functions, so your antimotility, anti-secretory agents, antiemetics, prokinetics, your pancreatic enzyme replacement therapy, insulins, ballast sequestrants, and your GLP-2 analogues. Now, I know you guys are actually slightly ahead with this treatment, but we have our first patient starting tetraglutide on Wednesday next week, which for us is incredibly exciting, so fingers crossed it all goes okay. We also can advise in micronutrients, IV, oral, and whether they're separate trace elements or as part of combined IV preparations. You've got your fluid and electrolytes, and also your antibacterial agents, so your catheter-related sepsis, line locks, exit site infections, and small intestinal bacterial overgrowth. So a fairly broad area, but again, it's not necessarily an exhaustive list. But the doctors obviously are so grateful, especially the junior doctors, because on ward rounds, we're the ones doing all the prescribing, and then they can get on with all their other jobs, bless them. So now I'm going to talk about very briefly just about kind of the patient journey from when they're referred to us to when they leave. So new patients are referred to us through a specialist IF referral form, which are coordinated processes, and these referrals are for PN or IV support and / or surgical assessment. During a patient's hospital stay, we assess whether they need home intravenous support, because even though they're referred to us, they don't always necessarily need it. And also determine the most appropriate regimen to ensure stability for the patient. Length of stay can range from 3 months to 2 years, depending on that patient's condition and their progress. If a patient is transferred for surgical evaluation, we assess their anatomy, their fitness, their nutritional status, and determine if they're ready for surgery on that admission or if they need to go home for preoperative optimization, which most of our patients unfortunately do, due to the fact that they usually come to us in a bit of a heap. So they usually go home and then they're readmitted for that surgery. Once the patient condition is stable, we then as pharmacists reach out to the home care providers for essentially support for their discharge with home intravenous support, and that's with or without nursing support as well. And then once that home care is arranged, the nurses then, our specialist nurses, send out the registration forms, we send out the prescriptions to the relevant provider. From them being stable to us contacting the home care companies usually reply the same day. Then the registration forms, prescription forms are all sent, and then it's 5 working days until that patient can go home. So it's quite a quick process for us, potentially quicker than your process. We obviously support them with all sorts of answers to their questions during that discharge process, and as Karen mentioned, where possible we offer that psychological support because it's such a change in these people's lives. We also unfortunately don't have a psychologist on our team, and it's one thing that we are striving for, but other centres in the UK do. We organise blood tests 2 weeks post-discharge and then have an outpatient clinic appointment 6 to 8 weeks after discharge. And each patient receives the folder with all sorts of contact numbers and information for their support. Our IF coordinator manages patient phone calls from the community for our patients, and any questions or concerns that they have, they then bring it to us. For ongoing care, typically patients attend clinic every 3 to 6 months, obviously depending on their stability, and these follow-ups can be conducted either in person or via phone call. So just a few cases that I'm going to discuss. I will cover some of the stuff that Karen's done, but I'll just go over it fairly briefly. So this is a patient that was referred to us for HPN setup, and I'm just going to discuss how we generated their kind of long-term prescription. So it was a 23-year-old male transferred from another hospital for nutritional and surgical assessment, and they were referred to us for HPN for short bowel. They had a background, very similar case, they had a background of ischemic bowel, and they had a jejunostomy formed. They had 100 centimetres small bowel from their DJ flexure to the jejunostomy, and then they actually had 1 metre of small bowel in continuity to their anus. Their weight was 55.4 kilos, and they had a BMI of 18.1 with no known drug allergies. So just a question for you guys. How would you roughly start off creating a prescription for this patient? They've obviously been on PNM for a little while, so this is their bespoke prescription. What would you start with? If anyone wants to answer, you don't have to.
What's their blue leaf?
Yeah, absolutely one of the things that we would think about. So we always start off with their macronutrients, as Karen did. So first of all, we start off with the total energy expenditure they require. If they've got a BMI of less than 18.5, we use 25 to 30, as with this patient. If they've got a BMI of 18.5 to 30, we use 20 to 25 kilocalories per kilo. And if they've got a BMI above 30, we use the Mifflin equation to calculate their total energy expenditure. We also have a correction factor that we use, which is part of the PEND guidelines for their physical activity level. So usually our patients as inpatients have a correction factor of about 1.2, but some of them, because they're there for so long, and we do a physiotherapist on our ward and we do push our patients, so sometimes it can be 1.4, and then for home patients obviously 1.6, because they're moving about a lot more and doing a lot more. We then look at their nitrogen requirements. So because this patient is has a BMI of less than 18.5, we pushed it to the top end that we use of 0.24. And then again, mentioning the lipid, so there's a maximum of 1 gram per kilogram per day of lipid to prevent the risk of intestinal failure associated with liver disease or IFALD. And then from there, so from minusing essentially the nitrogen requirements and the lipid requirements from that total energy expenditure that you've calculated, you can then get your glucose requirements or carbohydrate requirements. You then look at that lipid glucose ratio, which we prefer to be between 30 and 70 or 40 and 60 as a ratio, roughly in that region. And then again, the reason we do that is to again reduce that risk of IFALD for those patients. As Karen mentioned, the other thing we need to think about is fluid requirements. So, I mean, different healthcare professionals look at different values and different trusts do the same as well, but we roughly do it as if you're older than 60 years old, you need a rough fluid requirement of around 25 ml per kilogram per day. If you're younger than that, we say about 30 ml per kilogram per day. Some people go up to 35. It's a rough number, essentially, just to get a baseline. So this patient was a young guy. So we did the 30 ml per kilogram per day. You then look at their average stoma losses, which was around 1400 ml. So roughly a day, they needed around 3 litres of fluid. We then look at their electrolyte requirements. So we use this beautiful diagram, which is very similar to the diagrams that we had earlier. But it basically just says your sodium and potassium losses per litre, depending where those losses are in the body. So this patient has a jejunostomy. So you're looking at around about 140 millimoles per litre they lose and around 5 millimoles of potassium. So you calculate their maintenance electrolyte requirements and then add in their losses. Obviously, magnesium can be lost through stomas quite significantly, and we just base those levels on blood results in terms of what we need to increase to. So for this patient, you're looking at around about 250 millimoles of sodium, 65 millimoles of potassium, 8 of magnesium, 7 of calcium, and 30 of phosphate. Again, very similar actually to the patient that Karen had. So we always try and test their micronutrient levels if we can. Obviously, if that CRP is high in that acute phase response, those levels do skew, as Karen mentioned. So your iron, zinc, selenium, and vitamin A decrease, and your copper and ferritin increase. So if that CRP is high, those results won't necessarily mean much as such. So for this patient, thank goodness their CRP was 3, but their zinc and copper were both low. But all others were in range, so we decided to put them on combined IV preparations for their micronutrients, but then individually add extra zinc and extra copper. So we did around 200 micromoles of zinc and around 8 micromoles of copper, and we would measure them roughly every 3 months or so to see if those levels need changing. So, thinking of all of that and all the things that we've just calculated, we then put it into our prescription. So this is a prescription of bespoke prescriptions that we use for patients on our wards. Unfortunately, we are still paper-based, but in the next few months, we are looking to go electronic, which will be semi-exciting but scary. Anyway, so all those numbers are now plugged into a prescription. On the ward, we usually infused our PN over 16 hours, and that's actually used for the nurse's sake, so that handovers and bits and bobs for taking down and disconnecting and connecting PN. Sometimes we do infuse over longer, for example, if they've got blood glucose issues, edema, etc. And sometimes we do use and infuse shorter, i.e. for setting up for home. So we also calculate those glucose oxidation rates, or GORs, and it should preferably be less than 7 milligrams per kilogram per minute, again to reduce that risk of IFALD, or intestinal failure associated liver disease. So for this patient, they're with over 16 hours, their GOR is actually 5.52, so perfectly acceptable. However, if we were sending this patient home, again, we try to put them on 12 hours if we can, but for this prescription, this would be over the 7 limit, it would be 7.35. For some patients, we do accept a higher GOR, for example, if they're exercising lots and they're using that energy, but obviously if they've already got liver issues or their LFTs are abnormal, we wouldn't stretch over that, and they would have to accept that they would be going on PN over slightly longer at home. Now, this is obviously a complete bespoke prescription for patients, but in the UK, we do strive to always match patients to off-the-shelf bags. I think we've got more options in terms of off-the-shelf bags, potentially in terms of you guys here. And then we also, if that's not possible to complete off-the-shelf bags, we then also strive to match to hybrid regimens, so where they're on some nights bespoke and some nights off-the-shelf. We as pharmacists take up the main role of matching patients to these regimens, and that's essentially because we do the home care side of things, we're more aware of the bags that are available. But our dietitians do find this incredibly helpful and supportive in the discharge process. So just a brief touch on another case. So this is a medication management case. So another area, obviously, where we can provide advice and input. And this is just a type 1 intestinal failure patient who had some oral medications. So it's a 79-year-old who was admitted due to 2-week history of abdominal pain and vomiting. They then had a CTAP, which showed small bowel obstruction, likely adhesional, with a single transition point in the pelvis. An NG was inserted, they were placed nil by mouth, and they were conservatively managed. They had a weight of 61 kilograms and a past medical history of ovarian cancer, bilateral salpingal oophorectomy, and a total hysterectomy in 2019. They had Parkinson's disease, chronic pain, and a recent PE. So as there's no pharmacists in the building, I'm just going to kind of move past how you would necessarily manage patients' medications. So we have a very handy calculator for Parkinson's medications. We use an optimal calculator. It's just the name of the calculator that was named. So we essentially input all of the Parkinson's medications and come out with a patch option. So that was the one that came up with this. Obviously, this is just a baseline. If they start having more symptoms, we increase it, and if they start having side effects, you decrease the medication. We then had to look at their pain relief, which was their chronic pain. So we essentially convert the oxycodone into the equivalent oral morphine dose, and then that oral morphine dose is then equivalent to a patch dose. So for this patient, it was a buprenorphine, 20 microgram per hour patch. And then you obviously had to look at their rivaroxaban, which they were using for their recent PE. So that needed to be converted to a subcut dose. And for this patient, it was enoxaparin 100 milligrams. So obviously, having this in a type 1 patient is great, but if you're type 2 and type 3 patients who are going to be on a long-term PN and potentially not going to be able to absorb a lot of oral medication, this is a key part of our role, is providing advice to our doctors in terms of their medication management. So I'm just going to briefly touch on a few other cases, complex cases that we've had recently. So we had a patient who required 3.5 litres of IV support. They didn't actually need PN because when we had them on PN, they were eating and they were actually putting on a lot of weight. So they didn't need PN, but they needed the fluid. However, they also had hypochloremic acidosis of an unknown cause, so essentially they had high chloride. And therefore we couldn't give them chloride in their IV fluids, and they all had to be switched to other alternative salts, and therefore required a bespoke prescription for this. So we as pharmacists advised the doctors on all the salts that they needed to switch to make sure this patient was stable and to reduce that chloride burden. They also unfortunately had a line infection while they were with us. So we were worried because we couldn't give them off-the-shelf fluids because they all have chloride essentially in them, and therefore you would worsen the patient's hypochloremic acidosis. So we as pharmacists actually calculated the osmolarity of their bespoke fluids that they were on to see if we could give it peripherally. And the bespoke fluids they were on were actually less than the 850 milliosmoles per litre, which is kind of the threshold that we like in terms of giving things peripherally. So we were, during that line infection, we were actually then able to give those bespoke fluids peripherally and keep that patient hydrated while they're also not therefore worsening the chloride burden. We also then supported the nurses throughout this process by advising on switching all the diluents to other options that weren't chloride based. We also had another case where a HPN patient, they'd been on HPN since 2020. They did eat and drink as able, but they had a background of gastroparesis and slow transit constipation. And they failed enteral feeding, unfortunately, so they were placed on MCB with oral micronutrients. We were made aware of their pregnancy at the very beginning, but advised there was no need to change their PN because they didn't have any IV micronutrients or vitamin A specifically. So they carried on with the usual regimen. They understandably had reduced oral intake during their pregnancy, and then at their next clinic appointment, which was 28 weeks, we had their bloods taken, and they had significant micronutrient deficiencies. Fortunately, though, the baby had normal growth. We then admitted the patient, and as pharmacists, we advised on the safest options for IV micronutrients in terms of replacements and dosing, what doses to give. Unfortunately, understandably, there's minimal information on IV micronutrients in pregnancy, but we decided the safest option to use was the combined IV products rather than individual trace elements, because all the individual trace elements are unlicensed. We did look at the vitamin A content in the IV combined products and worked out that it was safe to give for that patient. We then generated a HPM plan for this patient and ordered a bespoke bag and included the IV micronutrients in that bag, and also increased the calories for that third trimester. Fortunately, the baby, this was back in July of this year, the baby was born fit and well, and as was the patient, that she was also well post C-section. So that was a slight panic from all of us, but we got them there. So just finally, some take-home messages. So as you can tell, the nutrition support and intestinal failure pharmacist role is fairly multifactorial. We're able to provide support in the provision of oral nutrition supplements, enteral nutrition, and also parenteral nutrition. We can provide advice in compounding and manipulating PN, electrolyte fluid management, and also we're the experts in medication management. We're kind of the experts in the pharmacology behind medicines. So we can advise on micronutrients, IV antibiotics, routes and formulation switches where appropriate, and also therapeutic drug monitoring, which is quite important when patients start tetraglutide, because obviously their absorption increases. So quite excited for that to come. We can also advise in the procurement of new medicines or medicine switches if there are shortages, and also cost savings where appropriate. We, in the UK, manage the HPN side of things and the home care contacts. We can also provide support in teaching, QI initiatives and research, and also as independent prescribers. As I said, we can support the MDT team by reducing the burden of prescribing. There's a few references and resources there if anybody's interested, and thank you for listening.